I'm Dr. Lawrence Friedman, and I'm joined by Dr. Shivangi Kothari, and we're delighted to introduce the AGA clinical practice update on pregnancy-related gastrointestinal and liver disease. It's important in patients with gastrointestinal and liver disease to do preconception and contraceptive care counseling and to coordinate the birth for a pregnant patient. I think the key point is that the providers should include all of those relevant to the patient's condition: the primary care doctor, the gastroenterologist, the hepatologist, an obstetrician, and a maternal fetal medicine physician. There are certain conditions that are common during pregnancy, and Dr. Kothari will comment on some of these, starting with the very common problem of heartburn, nausea, and vomiting. Dr. Kothari.
Thank you, Dr. Friedman. Thank you, AGA, for inviting us to be able to write this CPU. As gastroenterologists, we often face patients that are pregnant and various diseases that are either unique to pregnancy or that can worsen during pregnancy. And one of the most common ones is nausea, vomiting, which can be managed from the simple dietary lifestyle modifications and avoiding trigger foods or trigger situations to an step up approach of either vitamin B6 or doxylamine and ginger, and up to moderate to severe symptoms would either require metoclopramide or promethazine or even steroids.
Thank you. Of course, a common problem in younger people is inflammatory bowel disease. And what words of advice do you have for patients with inflammatory bowel disease throughout their pregnancy?
So the goal with inflammatory bowel disease is to make sure that the patient is in remission at the time of conception, through the pregnancy and the postpartum period. And those are the ones that have the best outcomes with the pregnancy and as well as with fetal outcomes. And studies have shown that patients that are in remission throughout their pregnancy do similar to their non-pregnant IBD cohorts. The goal is to manage these patients in a multidisciplinary manner with the obstetrician, the MFM experts, and the gastroenterologist, and continue their medications that is holding them in remission through the pregnancy and postpartum period. Methotrexate, thalidomide, and ozanimod are contraindicated during pregnancy, though they should be stopped 6 months prior to conception.
Well, there's a wealth of information in this clinical practice update, and we encourage you to read it in the October issue of Gastroenterology. And we thank the AGA for inviting us to prepare it and to present this introduction.
Thank you.